It's high.
Yes.
Wait, Dr. Patsy's still here. She just made a face.
We're waiting for the scores to...
The basic scores are really good. I was going to shut the door. So, very high score, the bottom score very high, so now I'm just going through. So, there were 300 people that wanted your spot, so I don't know why you're worried about, even if you're at the bottom, you're way above the other 270 people that wanted to be here. So.
Thank you. How do I call that? You can't.
I'll tell you what.
I mean, it's true. I mean, you know, when I was in PA school, I don't remember how many were. I think it was bigger because there weren't as many programs. I think they had, I want to say, something close to like 7 to 1,000 applicants, and we were to vie for 50 slots. You know, and I think they interviewed around 300 people versus here we interview about, I don't know, 115, 120 for 36 spots. So you guys did good. She's not lying. So, okay, now that you guys are all nice and refreshed from lunch, we're going to talk about pituitary gland disorders. Now, let me preface, she said I'm not a know-it-all about pituitary gland disorders. I know about pituitary adenomas because that's where it's all up in the head. Now, when we get to SIADH and what's the other one? See, I can't even think about it right now. We're gonna go with it. So, because diabetes insipidus, that's the other one. So we're just gonna wing that one. So, okay. And I looked over Professor Polk's lecture for you guys in physiology, so I didn't want to do too much of repeat, because you guys just had that on the exam, right? Or is she saving the pituitary for this next exam? So is all that clear as mud?
No.
No, I mean, I honestly think the anterior pituitary is much more straightforward than the posterior pituitary. Do you all agree? Okay. Okay, so just anatomy refresher. Pituitary gland is connected to your hypothalamus by a pituitary stalk. Sometimes it's called the infundibulum. And then you have that also delineated to the posterior and anterior pituitary. A lot of times people call the posterior pituitary not an actual gland, they actually call it part of the brain because it's so full of neural tissue. Okay, so that's where that's at. Does that even vaguely remind you of the cross-section and anatomy? And this is just another view of the pituitary gland and what it's all surrounding. So even though it's a tiny little gland, it's surrounded by a lot of important things. So you have all your cranial nerves, the optic chiasm, so when these get big, people start developing visual issues, and then also sphenoid sinuses, so you can see where it gets real big and people start having issues. This is just another cross-section on an MRI, picture of it. Has anybody ever had an MRI of their brain in the head? You ever look at your MRI? I've had one, and I'm like, oh my God, look at this fat pad of my head in the back, because you're laying like this, you know, and your fat rolls are all tucked in, and I'm like, oh my God, it's horrible. And of course, I'm looking at it, I'm like, oh, look at my base of tongue, because that's what I'm all concerned about, because you can never see a base of tongue tumor. But then I look at all of those, and I was like, it's really freaky to look at your own MRI of your brain. And this is a nice little chart. I don't know if you guys got a chart like that in physiology. It's just a schematic picture of which side of the gland and what hormones that it releases. So this is a nice little study guide. I mean, I thought it was really helpful. And she did go over that with you guys, right? Okay. So then, this is again just a repeat of the hypothalamic pituitary target gland axis. So basically, you know the hypothalamus excretes releasing hormones, and then that stimulates pituitary to release stimulating hormones. So that occurs in the anterior pituitary. Posterior pituitary, the hormones are already made within the hypothalamus. So that's the difference. So you separate the two. And just remember, if you can remember the two that are produced in the posterior, everything else is in the anterior. Okay? And then the only difference is prolactin is more of an inhibitory control of dopamine versus a secretory release. Oh, and I forgot to tell you, so don't forget that the pituitary gland is located in the sella turcica. Y'all remember that? Okay. You work two screens here. Okay. Did it go to hyper? I just missed it. Okay, so, and I don't know if you guys, I mean, I'm sure you guys really realize the difference between a hyper and hypo states, right? This is just a small breakdown, just in case it doesn't make quite sense. Because, you know, with hypothyroidism, which I'm sure you guys realized, it's so different. You would think for hypothyroidism, you would think your TSH would be low, but it's actually opposite. So this just kind of gives you a better definition, might help you with med terminology, about hyper and hyper states. So primary disorders are usually the target gland. So something is wrong with your thyroid and it over-secretes, and that's a primary disorder. Secondary disorder is there's something wrong with the axis, either the pituitary or the hypothalamus is malfunctioning. And then you get ectopic site disorder. So somewhere else in your body it's producing the hormone other than where it's supposed to be making. So sometimes an ovarian tumor, small cell lung cancer. So a lot of times people who have lung cancer don't know that they have lung cancer. They just think they have excess of some hormone, then they come to find out it's because they have lung cancer. So, and then sometimes it can be from genetic mishap of your target hormones, from a mutation. And then hypostates, same thing. Primary disorders is congenital or acquired of the gland. And then secondary is the pituitary doesn't put out enough stimulating hormone in order for you to get secreted by that target gland. And then tertiary, the hypothalamus does not secrete enough releasing hormone at all. And then the very last comment is something about diabetes insipidus. So we talk about at the end there, where sometimes you're low in ADH, so you try to give them ADH, and it actually doesn't work because it's not effective. It's not the really reason why you're developing ADH, or hypo ADH levels. So that's what the last one is about. So when studying, these are the questions I would ask yourself. What hormone does this organ secrete? And what stimulates it to do so? And then what would happen if the organ were over-secreting or under-secreting? So that helps you determine which one's the hyper-secreting and under-secreting diseases. And then how would these states affect the various hormone levels in the negative feedback loop? So again, you would look at hyperthyroidism. What would your TSH be? What would your T3, T4 be? Those kinds of things to help you kind of delineate and differentiate them. And then how will this affect lab findings? So you look at what's hypothyroidism, what should the labs look like, hyperthyroidism, hypoparathyroidism. Which, have you guys gotten that yet? Okay. And so again, this is just a list of the pituitary glands. And so the main ones we'll talk today about are the growth hormone, and you guys already had someone discuss in length of the TSH, and then the ACTH. I think Dr. Vanetta is going to just go over that tomorrow with you all. Or is that the one he videotaped? So you guys don't have class tomorrow?
Not tomorrow, in the afternoon.
In the afternoon with him?
It's like home
It's
study, self-study.
Oh, okay.
Sorry.
And then we'll talk about prolactin or prolactinemias, and then FSH, and LH will probably be more discussed in your OB-9 module, okay? And then the posterior pituitary hormones. This is not I still do think I'm brain tumor. After studying all this pituitary, I was like, maybe I have a tumor on my cellulose. Okay. I can't wait till you guys go out on rotations and you call me and you're like, oh my God, I think I really have something. So pituitary adenomas. Again, so this stuff I really know just because we saw it all the time. And again, I thought it was very common just because I saw it all the time. It actually really isn't. However, pituitary adenomas are slow-growing, benign tumors. So a lot of times when you hear celebrities who have had brain tumors and they've had it, there's one, I can't think of who it was, that's had multiple surgeries on it. It's usually a pituitary gland tumor. Has anybody in here ever had a pituitary adenoma? Do you know anyone who's had one? Seen one? Oh.
I knew a guy who had one, and he knew because he started lactating.
Isn't that crazy? So there was actually a PA that, she was an underclassman of mine, I think she was maybe 2 or 3 years below me. She ended up having a pituitary adenoma, and she only noticed because she developed acromegaly, so we'll kind of talk about that here in a minute. So pituitary adenomas have been identified as the third most frequent intracranial tumor, about 10 to 25% of them. So they are usually classified as microadenomas or macroadenomas, so depending upon their size. They obviously oversecrete hormones, and they can compress, causing hypopituitary symptoms. So a lot of times these adenomas can get big. So remember in that picture, that cross section, if it grows superiorly, people will develop what? Visual problems, right? Or even laterally, they can develop vision problems because it's your cranial nerves on the right side. And then if it grows inferiorly or down to the base of skull, then you can develop CSF leaks. Okay, and then males to females, so I saw a lot more females that had pituitary adenomas than men, and the age increases with incidence, and then you can also have a risk factor if you have something called MEN, multiple endocrine neoplasia. Did you guys talk about that in thyroid disorders? I saw the multiple endocrine neoplasias more with people who had parathyroid issues because their calcium levels are always out of whack. But again, usually if you have MEN, you just have a higher incidence of recurring pituitary adenomas. But generally they don't become cancers with MEN, but there have been, I think I read something about 3 different studies where they actually did become cancerous. So signs and symptoms. So mass effect. So like I said earlier, if it grows up, you can develop what's called bilateral hemianopia. It's where you lose the temporal vision. You only see manually. And then you can develop what's called a hypothalamic syndrome. So these people get really thirsty, they're hungry, they're sleepy, and they're hot a lot. They sweat a lot. And then lateral extension we already talked about, and then inferior extension. I did tell you guys about this nurse at OU. Did I tell you about this back in ENT? She has talked to one of my ENT surgeons because she'd been walking around for a year leaking CSF. Turns out she had a pituitary adenoma, but she thought it was a runny nose. If you guys ever see one, I'm telling you, it looks like a leaky faucet, like water. It's not like the mucousy, snot. It's like clear water running out of their nose. So how do you diagnose it? So you would check levels, so all hormone levels. And then the treatment for pituitary adenomas, most of the times we did it was to surgically remove them. You can give them, I think it's drug therapy to help decrease the size of the pituitary adenomas. But most of the times, by the time they're coming to see us, they already have neurological symptoms. And so the best way to decrease that is take it out. So you can simply observe it if it's small and doesn't have any mass effect, or it's non-functioning, which means it's not secreting excess hormones. So we used to use a transsphenoidal approach. So our surgeons would put them to sleep, go through their nose, and it took me the longest time to figure out where is it within the nose. So I don't know if I'll be able to pull this video up, but so we use a transsphenoidal approach. They go through the nose. It's usually done with a neurosurgeon and an ENT. Usually the ENT will, I can't remember if he does the approach and resects that base of skull. The surgeon goes in, pulls out the pituitary adenoma, and then my surgeon would put the flap on, the septal flap, to close it up. And then they would use something called a trumpet. So there's these big, it's kind of like similar to people who get rhinoplasties, but it's big and round, and it's really long. It goes all the way down to the posterior oropharynx sometimes, and people can kind of see it if they didn't trim it too short. But usually that is stuck there, and it's left there for, depending upon how large the tumor was and their symptoms, it could be left up there for 3 weeks. And it's usually adhered by a stitch to their septum. So imagine after 3 weeks, you've got this thing in your nose, all the pressing, you can't blow your nose, can't sneeze out of your nose, and so it's usually pretty stuck in there. And I remember the first time I ever had to remove a trumpet from a young female. She was crying, and I thought I was going to cry. I thought we were both going to pass out. And I was so nervous because I'd only seen one. I mean, literally, it was like my second week there. And they're like, okay, go in and remove that trumpet from that girl. I was like, what, by myself? And so I went, I mean, I really had to talk her down off the ledge. So I told her, okay, this is how you're going to do this. It's not that whole primary motion. So she was really scared. And I told her, I know this is really scary, but the thought of it is worse than the actual action. So I snipped I took my little scissors and cut the stitch. I hadn't even pulled the stitch out yet. I just cut it, and tears started flowing. So I was like, oh my God, I hope I can do this. So then I took the pickups and I pulled that stitch through. So you have to pull it all the way through from one side to the other. And it's been there for a while. So I yanked it through, and her eyes watered again. Because that's the worst part, I tell patients, is pulling out that. And then came that she had to sit down for a second before I could go and actually pull it out. But once I pulled that whole thing out, she was fine. So what you have to look for, though, is once you pull it out, I have to take the section and clean it out. It's Booker Picking 101. You got to section out all the mucus that's been sitting there for 3 weeks so that she doesn't blow her nose. And then you have to keep her there for a little bit to see if there's any leaking. So what you worry about is once you remove that trumpet, which is holding the flap up against the skull base, if you remove it, if it's adhered, it'll pull that flap down. Or if that flap hasn't healed well, it'll all come falling out. And then what's behind there is your brain and see if vessels start leaking. So that's what you watch for. And when patients come back, you want to bring them back. You have to bring them back in a week to ask for about any salty metallic taste in the mouth. Because a lot of times they may not even have any rhinorrhea. It's just a salty metallic taste in the mouth. And then you have to really clean out their nose, teach them, nasal hygiene. But then once they're done, they do really well. Their diplopia disappears, the polyuria, polydipsia, it all goes away. So see, this is where, when y'all go on there, does it do anything? Is it just blank? See, but I don't know how to get it to play. Does anybody know?
I think you have to close out of the PowerPoint.
Yeah.
And then click on it.
Close out the PowerPoint?
Like out of slideshow mode, right?
I
It's
think
just
so.
Yeah,
on the
I
presenter
think that's
mode.
right.
I think if you hit escape on the keyboard, it'll do it. Performance.
Anyway, I had a really cool video I was going to try to show you all, but I can never figure it out.
Can you move the mouse over to this screen? Sometimes that. And then click on it.
Oh.
Smart.
is a small gland, but
Oh, man.
It looks like it.
Oh my gosh, I've really done it now. Where did it go? Oh.
There we go.
It's gonna be really tiny.
the pituitary gland is a small gland, but
Can you get
it's
the volume
just
to go up?
under the brain. And it controls most of the hormones in your body. It's a bit like the director of it.
Isn't the volume
I think
up
they're
there?
on the top right. There's
Top right.
no,
Not on the computer. The control panel.
Not on the control panel?
no, not on
Like
the.
on there.
Yep. Is there a volume?
Oh, that's really loud. So be ready.
Embrace yourselves.
The pituitary gland is a small gland like lies just under the brain, and it controls most of the hormones in your body. It's a bit like the director of an orchestra. Pituitary tumors can grow slowly, and they can start to compress the structures under the brain. Once the tumor is diagnosed, we'll discuss the findings with the endocrinologist, the neurosurgeon, the neuroradiologist, and then we will find the best treatment for the patient. My name is Dominique Venn. I'm a neurosurgeon specializing in brain tumor surgery. The most important part to make a surgery safe is to plan it properly. So these tumors are usually approached either through the nose or under the lip. And the first part in the nose is done by the ENT. Then the second part of the surgery, which is the tumor removal, is done by the neurosurgeon. And this is a surgery that's been done for more than 100 years. But now with the technology, it's extremely safe. What helps neurosurgeon is the visibility. So we use microscope or endoscopes to see the
You can do
tumor.
this all through the nose.
And during surgery, we use a navigation technology, which is a bit like a GPS, and it recreates the brain in 3D. And all our instruments are tracked by the system, and we can follow our instruments in this virtual brain.
You know, born that as
So
a
this
resident.
makes the surgery very simple. And there's no external signs. It's either under the lip or in the back part of your nose. The first part of the surgery is the opening of the nose. That can be done directly in the nostril. Then, once we reach the back part of the nose, we open the sphenoid sinus. The neurosurgeon will come and will open the base of the skull to reach to the tumor. We remove the tumor very slowly, carefully, and once the tumor has been
That's what
completely
my mom
removed,
surgeons did.
then we reconstruct the skull and we remove the endoscope, and that's the end of the surgery. Patients usually will wake up in the operating room, and then they will be transferred to the intensive care unit, where they will stay 1 night. After 1 night, they go to the regular floor, where they will be followed for a few days, 3 to 5 days. We will measure all the hormones in the patient to make sure that they don't need additional medication after surgery. And then they will be discharged, they will go home, but they will be followed on a regular basis in our clinic by the endocrinologist, the ENT, and the group of neurosurgeons. Sometimes during surgery, we will find that the tumor invades or surrounds important structure. And at that point, we will decide maybe to leave a small remnant of the tumor. If we have to leave a small tumor remnant, patients might need also other treatments, such radiation therapy. The brain is the most important organ of your body. It is very fragile, and this is why as neurosurgeons, when we operate inside the brain, we take all the precautions not to touch the brain. We use normal corridors to avoid any retraction or pressure on the brain.
So that was kind of cool. But it's funny is the neurosurgeon was talking about, oh yeah, they follow up. Yeah, the neurosurgeon's like, I took it out, now you follow up with everybody else. If there's a problem, the only time the neurosurgeon wants to see them again after their first post-op is if they have a leak. Because because then they have to go back in and they have to put them back to sleep and they have to fix the leak. Okay. Okay, indications for surgery. So, like I said, surgery is first line for those who are severely symptomatic, and a lot of times we would see them coming into the ER because they woke up and they've lost their field of vision. They've got headache, that kind of stuff. But and it's useful if they try medicine, or if it's small, they try radiation, and that still doesn't help shrink that tumor or relieve their symptoms. Like I said earlier, it provides prompt relief. And then indicated if pituitary apoplexy with compressive symptoms. So pituitary apoplexy is when you have bleeding from a pituitary adenoma. And a lot of times you have that with pregnancy, so post-hemorrhaging in a woman who delivers. Yes?
Can I ask a question?
Yeah.
It might be silly, but whenever you're going in through the nose to take out the tumor, do you take the whole pituitary, or?
No, you just take that adenoma.
Can you distinctly see it?
No.
Okay.
I never asked my surgeon that. Because, and it's just kind of like the thyroid now if you have a thyroid cancer, when you go in, most of the times they try to remove as much of the thyroid cancer as they can. But a lot of times, like you said, if it's attached to certain structures, you have to leave a bed of the thyroid behind. And those people end up with radioactive iodine afterwards, and they have to be followed with serial imaging. So I'm assuming it's the same way. I think they just take out the adenoma like a thyroid nodule, or it's embedded within the pituitary, or the thyroid, and you'd have to take the whole lobe out. And honestly, I can't remember if the adenoma is separate or if it just grows attached to the pituitary. Okay, so disorders of pituitary function. So ACTH, like I talked about, Dr. Manetta would cover that tomorrow, which is Cushing's disease. And then TSH, hyperthyroidism, you guys have already had that covered. So today we'll just kind of talk about hyperprolactinemia and acromegaly. So it's just a nice little picture for when you start studying about ACTH. So those people with increased cortisol secretion. And again, when I was studying this, I was like, I think my friend might have ACTH, because you think you see those people with like kind of big middle sections and then tiny arms, tiny legs. They're usually, you call them apple shaped, right? I was like, maybe she has a pituitary adenoma. I'm always looking for zebras instead of horses. And then secondary hyperthyroidism from the pituitary adenoma. So for hyperthyroidism, what do you guys see on a TSH?
Low.
And what is usually elevated, T3 or T4? When's T4 elevated?
TSH is down.
T3, T4, you can have hyperthyroidism with an elevated T4 and a low TSH. But some doctors only order T3s, some of them look at T4s. So what did she say when she came and talked to you guys about hyperthyroidism and hypo?
I
She had TSH first and T4 second, and she hardly looked at T3.
She hardly looked at T3? Because I can't remember, T3 is more the, well, T4 can be autoimmune as well, but I don't remember ever looking at T3s. We mainly looked at free T4s and TSHs. Okay, prolactinomas. So it's the most common functional pituitary tumor. These are usually microadenomas. And they can be a space-occupying macroadenoma. And these people, again, you'll get the visual defects in these people. Although many women have hyperprolactinemia, they will have galactorrhea and or issues with their menstrual cycle. But the absence of these two signs do not exclude the diagnosis, because you can have that for many other reasons as a female. Now, if a male shows up with galactorrhea, you should first think pituitary adenoma. And then for prolactinomas, the gonadotropin releasing hormone releases are decreased in direct response to elevated prolactin, leading to a decreased production of LH and FSH. So it's that whole feedback loop. And that took me a while to reread that sentence over and over as I typed it. But it made sense by the time I read it like the fourth time. So again, prolactinomas in women, which you'll see is galactorrhea. And in women, we're more heightened because we know we should not be producing milk if we're not pregnant, right? So a lot of times they will show up because of that early on. Men, one of the first signs may be impotence. So they may not show up because there are many other causes and reasons why they may have sexual dysfunction. So they may come in a little bit later. But with women, you can have hirsutism, decreased libido, same as in men. You can also develop gynecomastia in men. So remember, gynecomastia is just excess breast tissue in men. And then in men, you tend to have larger lesions. And with the larger lesions, you get more of the mass effect symptoms. So with prolactinomas, like I said, you got to make sure you rule out other secondary causes. So has Dr. Latassi done your lecture on drugs, things that can cause prolactin? When does she do her lecture?
At the end of the week.
Sometime this week?
Thursday, maybe?
So she'll kind of go over drugs that can cause prolactinomas or decrease dopamine stores. So that would be phenothiazine, amitriptyline, I don't know if that last one, oh, can't say it. I have some issues sometimes, it's just like my classmate who could not say penicillinase. I can't say that word. So, Craniopharyngioma. Did I say it right? Okay. And then you have factors that inhibit dopamine outflow, such as pregnancy, estrogen abnormalities, and exogenous sources. And then also hypothyroidism can also decrease dopamine levels. Now, if you draw a blood level and the prolactin level is greater than 200, it's almost always a prolactinoma, even in a nursing mom. So their levels won't be that high, okay? And then, obviously, the bigger the tumor, the higher the prolactin level. And then you want to suspect a different type of tumor if their tumor is large, but the prolactin level is low, so it has to be coming from somewhere else. And so how do you diagnose this? So you would do labs. So with all the anterior hormones, you know, they're usually secreted in bursts. So they're pulsating. So you may have to do multiple draws, or a lot of times you do a baseline draw and then a morning prolactin level. Same with testosterone. If you ever had to check a man's testosterone, you want to do it early in the morning because their levels surge throughout the day. So like I said, multiple measurements may be necessary. You can have a lot of both false positives and false negatives. So falsely lowered because of markedly elevated prolactin levels. So it's that whole negative feedback loop can give you false positives, or I'm sorry, yeah, false positives. And then maybe falsely elevated by other forms of circulating prolactins, like if you actually have macroprolactinemia, so it's in the blood circulating, rather than actually a tumor. And then hypothyroidism should be excluded by measuring TSH and T4 levels. Treatment, you can give them drugs, so dopamine receptor agonists.
Oh.
So dopamine normally inhibits prolactin secreting cells. So dopamine agonists are the first line for treatment of inhibiting the growth of the prolactinomas. So those are a couple of them. I don't know them, I didn't never use them, so I just listed there. I figured Dr. Latassi probably would go over those a little bit more. But then if the dopamine agonists fail, then surgical removal is often necessary. And again, would be the transpenoidal surgery. And here is just a little schematic. Again, I like to look at things and kind of go through it and help you decide what treatment and what to do and what to order. So what type of tumors are most prolactinomas? Macro or micro?
Micro.
And then prolactin levels greater than 200 always indicates what?
Prolactin.
And then do prolactin levels correlate with tumor size? And then what effect would dopamine antagonists have on prolactin? Y'all are so smart. Okay, so the next one is growth hormones. I think this was the more interesting out of all the hormones. Okay, growth hormone tumors. So these make everything big. So these people will have big hands, big feet, lips, tongue, and a lot of times it's so slowly that a lot of times people don't notice it. I mean, you as a patient may not notice it. Now, when they're younger, those people who develop excess growth hormone before fusion of the plates are termed to have gigantism. And then as an adult, you develop acromegaly, is a rare condition caused by excess secretion of growth hormone. And those are the overgrowth of hands and feet. So people ever, your patients ever say, you know, all of a sudden I can't, you know, other than if they don't have any weight gain, can't get my fingers on, my glove fits really tight, my hat is really tight. Those are things that you think, why is he all of a sudden having this surge of growth hormone? So that's something to think about. And that's what the PA that developed it, she developed acromegaly and her rings stopped fitting. And then she had other symptoms, and I think her prolactin level was high. But she developed acromegaly from it. Oh, I'm sorry, not prolactin, growth hormone. So, signs and symptoms, we already talked about. You may develop diabetes, glucose intolerance, hypogonadism, large hands and feet, a large head with a big brow, you know, hypertension, colon polyps, and then multiple skin tags. See, what I don't understand is why I use this. Sorry, I have little notes, and then when I type under the notes, it never goes with me whenever I go to type it, or move the page. So this is just some pathophysiology of acromegaly. So when you go to order something, you want to order an insulin-like growth factor, so IGF-1. That's what would be abnormal. And then greater than 90% with acromegaly, we have a benign tumor. Did I do that? See, this is what happens. You don't come down. I don't come down lecture, so this is what happens. I don't know what I would have touched. Okay. So the remaining 10% have ectopic growth hormone secretions. But but the majority of it, 90%, is from the anterior pituitary where they have no growth of the somatotroph, causing an adenoma of the anterior pituitary. Like we already talked about, signs and symptoms, they get enlarged hands, ring size, sometimes they can have headaches. These patients too will also develop bitemporal hemianopia. Sometimes you develop hand numbness, carpal tunnel, just because everything's big, it's pushing against nerves. Maybe fatigue, weak, or have some sleep disturbance. There's just more symptoms that you guys can read on your own. But a lot of times, women, they will, their facial features get more coarse, their voice deepens. And there's a picture I put in here in a minute that you guys can kind of see that. So again, presentation is usually subtle. You may not notice it, or the patient may not notice it until they start looking at pictures. Or you as a provider, maybe you've seen them throughout the years and slowly you kind of notice, well, her facial features get coarser, she looks kind of bigger, head looks larger, brow looks a little bit furrowed more. But then most of the time is they will complain of the visual changes or other cranial nerve defects. And then not only do they look like that, but their internal organs can also get big. Which I find interesting. So this is another nice little picture of someone with acromegaly. So see, here's a little picture of a lady over time. You see how her lips get bigger? Her facial features don't quite look so feminine. They look, her jawbone kind of gets bigger, her maxilla, her chin. I thought that was really interesting. Like you wouldn't think if you looked at her maybe from 1977, so in 11 years, look how much she's kind of changed her lips. She just looks a little bit different. I mean, it's not so huge, but it's markedly when you look at them side by side. And then how do you work up acromegaly? Like I said earlier, you do a serum IGF-1. And so levels twice the upper limit is more suggestive of acromegaly. You do some follow-up testing. You can do a glucose tolerance test. So it should drop to less than 1 within 2 hours. But someone who has greater than 2, it's usually those with acromegaly. So they do, I guess they have a desensitization to glucose or glucose tolerance. And then you do an MRI. So you look at the cella turcica, looking for a tumor. And the MRI is really good because it can detect very small tumors. I had a patient once that she had a pituitary tumor removed like 20 years ago. And then she just kind of started developing some vague symptoms. And it wasn't even like, you're thinking, what is wrong? There's nothing wrong. And then we did an MRI, and there's a very, very, very tiny tumor in her cella turcica. So treatment is surgical or radiation. Again, you can decrease with medication, and these are 2 different ones. Octreotide, I've heard that's been used for something else. Does anybody know what that's used for as well? It sounds familiar. Again, that's pulling from PA school. And another little nice little map. Did that turn your page? the Giant?
Yes.
Ever watch Princess Bride?
I love that movie.
Who here has not seen Princess Bride? Who has not? Everyone else has seen it? You haven't seen it?
Like half of one.
Paul, have you seen it?
I know the story, but I can't remember watching it all the way through. I know, is that the one where he's like, you killed my father?
Yeah.
Yeah, I know that.
My name is something Montoya. You
My
killed
name is
son.
Inigo Montoya. You killed my father.
Prepare to die. So, Gigantism. So, you know, another famous basketball player, Yao Ming. I'm pretty sure he suffers it. Somebody from the Thunder, I can't think of his name.
Steven Adams.
Maybe Steven Adams might be a
Steven
little bit.
Adams, he's got
Yeah.
that face.
They look it. You look at their face, you know, just looks not nice. You what?
He's from New Zealand too, they say looks like.
That's true. So again, it's caused by excess secretion of growth hormones prior to the closure of the epithelial growth plates of the long bones. And usually it's before puberty. And again, commonly caused by pituitary tumors, which the tumors block gonadotropin release, responsible for sexual development, so it may cause amenorrhea in women and impotence in men. So the growth plates is just a definition of growth plates. I'm sure you guys remember that from musculoskeletal. But so it's multiple layers of plate responsible for bone growth, open only before puberty, and excess causes thickening of that bone. And then, so before the onset of puberty, the cells in the first layer, they differentiate to something called chondrocytes, which are cartilage-producing cells, and then the second layer, composed of chondrocytes, responds to the stimulus of growth hormones. And so then after the chondrocytes mature, they deposit calcium into bone matrix to help form the new bone. These are just some defects, or growth hormone effects. So a lot of these people have issues with calcium and hardening of their bones. Oh, I wish there's some other disorder called cementosum, where you can have overgrowth of bone as well. And this patient used to have it in her face, and we try to always debolt her bone because it would just keep growing. And she kind of looked like she had a little bit of acromegaly. So this is a picture of a 12-year-old and his mother. And then the picture to the right is his hand, and then a 61-year-old man's hand.
Hopefully.
Look at that, he doesn't even fit on the door, you know, he had to duck his head to get under.
And he still has lots of work.
Yeah, he's only 12. So these are just some general facts I thought was interesting. So about 3 people in 1 million have pituitary gigantism. 100 cases to date in the U.S. They have a higher mortality rate, because can you imagine how hard everything has to work to regulate their body? There's no racial predisposition. Males and females are affected equally, and it's not a genetic disorder. These are just some signs and symptoms. Like I said, usually reduce significantly due to heart failure, respiratory problems, and skeletal muscular problems. So imagine all that weight on their weight-bearing joints, on their hips, their knees, their ankles. That's why I don't see how the basketball players do it. How do they run up and down the courts as big as they are and not have a lot of issues? They're tall in stature. They have large hands and feet, coarse facial features, and then some of these people can have chronic headaches, visual impairment, depending on how big the tumor is and how close it is to optic chiasm. So again, like I said, it's not a hereditary genetic disorder, so there's no prenatal testing. And initially, the growth is not exaggerated, but becomes more apparent as you get older. So you can do blood work to look for circulating IGF-1 levels and a CT MRI. Here's some treatment of gigantism. Obviously removing the pituitary adenoma. So I'd be curious, which I didn't read in this and I don't know, that once you remove that tumor, you know, do they stay the same size? I would assume they would, because all the bone growth plates have stopped growing. You can give them drugs such as octreotide and bromocriptine to block the GH effects, and then radiation to treat the tumor. So these are just some famous giants. So this was Robert Gershon Wabo. He was the Alton giant. He was the tallest man ever at 8 foot 11 inches. He was born a normal weight and size, but he was 30 pounds at 6 months of age. Can you imagine?
Wait.
But how tall was he? Huh?
Wait.
He was 8'11", but he didn't say. He just told me how much he weighed. 30 pounds at 6 months of age. But now that newborn closed a long time ago. There's Andre the Giant. So Andre the Giant was 7'4", and he weighed 500 pounds. That's what it says. Jill, I mean, she's probably too young, but he wrestled in the WWF back in the days. But again, you know, it's all fake. It's not real. Then it said here he was offered a position on the Red Series, but he turned it down to wrestle, which I thought was interesting. And then he had a role in The Princess Bride. And then he was later disabled in life due to joint pains and cardiovascular complications. And then this one, was kind of interesting too. So this guy, Matthew McCrory, he holds the Guinness Book of World Record for the largest feet on a living man. His shoe size, can y'all guess?
37.
29 and a half. He was 15 pounds at birth. He was 7'6", and he weighed 330 pounds. He worked for Dr. Scholl's on promotional tours. And then he became a lawyer and became an actor. I think he was in that movie.
Happy Gilmore.
Huh?
Happy Gilmore.
Oh, I don't know that. Was he? I thought he was in that movie Big Fish. Did you ever watch that movie?
Yeah.
With Ewan McGregor? I think he later died. Okay, so then you can have hypopituitaryism. So it's a pituitary tumor, but sometimes they cannot secrete anything. They can just grow and cause issues. So again, you can have bitemporal hemianopia and compression of the pituitary gland, causing dysfunction of the gland itself. So it can be so big it presses it. So other various tumors, radiation, autoimmune disease, and then again we talked about that pituitary apoplexy. And then you can have Sheehan syndrome, which is usually peri or postpartum hemorrhage from the placenta. And then the apoplexy, like I said, they'll have sudden headaches, worsening visual field defect, or double vision caused by compression of the nerve surrounding the gland when it bleeds. And these are just a list of things: hypopituitarism, loss of ACTH, so you have adrenal insufficiency, loss of TSH, secondary hypothyroidism, loss of LH, FSHs, hypogonadism, and in children you get a pubertal delay. And in adults, like we talked about, you get impotence, menstrual irregularities, infertility, and decreasing libido. So all these symptoms, you've heard it over and over because it's in the big umbrella of pituitary adenomas. So loss of growth hormone, though, during childhood, you can develop hyposecretion of GH, causes pituitary dwarfism, which I don't know that I don't remember learning this in PA school, but it's a condition in which the growth of the individual is very slow or delayed. So in this one, I'm only going to talk about pituitary, just because you have other genetic reasons for dwarfism, and that should be covered in pediatrics. But the epithelial plates close before normal height is reached. The end result is a proportionate little person, because the height as well as the growth of other structures is also decreased. This can be caused by gene mutations. So it's on chromosome 3 and 7, so don't have to worry about that. But just know that pituitary dwarfism can be caused by a tumor, pituitary tumor, or by a genetic mutation. And the most common tumor is a craniopharyngioma. It's a tumor near the pituitary gland in children and adolescents. So they have the same kind of symptoms: double vision, polydipsia, headache, vomiting. So look at, isn't that the whitest thing you've ever seen? She looks like a little doll. So that's the proportionate pituitary dwarfism.
So who was the guy holding that the little ball?
I don't know. But I think these are sisters. But look, I think she was, I can't remember if the one in the middle, if she was like 16, I think. But I don't know about the guy and the little girl. Or it could be a little lady, I don't know. But I just think it's so cute, like everything's small, but it's all proportionate. So signs and symptoms, obviously the growth rate would be very low. I mean, there's obviously other reasons why little kids can not grow, but they will have normal intelligence and capabilities. So how you diagnose these is you watch the growth chart. You know, that's why your pediatrician measures your child, gives them the growth weight and height every time you come to see them every year. And you just kind of monitor those if they fail to grow. That might cause a little red flag. And then x-rays to determine their bone age. So obviously if they look like those little people did and they were 14. Okay. So treatment, you can give them injections, growth hormone injections, several times a week or daily. The most common side effect is injections is fluid retention, joint and muscle aches. But I didn't seem to read and see how much would it help them grow. I think it has to be done early. I don't think it can be done later in growth. Y'all want to take a quick break and then we'll do the posterior. It won't be very long, but go take a break.